an evidence base that's sorely lacking in fatty liver disease, largely based around public health interventions and issues and related policy issues. And the final piece we just finished was trying to position NAFLD in the framework of the Sustainable Development Goals, to be able to say, if you're addressing this particular goal and has this particular target, it's also relevant for fatty liver disease. So what we're trying to do, and I say we, meaning hundreds of researchers or clinician researchers, is look at what's called the attributable fraction to understand, well, when people do die of liver disease, get liver cancer, what caused it? What's the attributable fraction to hepatitis C or to fatty liver disease? Because, without documenting it, people are dying of fatty liver disease and we don't know that it was actually fatty liver disease.
Hi, this is Roger Green, host of the Surfing the NASH Tsunami podcast. First, please let me be among the first podcasters and people to wish you and yours a happy new year. Now on to business. Over this weekend, we are offering 3 conversations from Season 2, Episode 64, the third and final episode of our year-end 2021 series, even though it's already 2022. This piece shares our entire conversation with Jeff Lazarus on the many global activities in 2021 that are building momentum towards the kind of global holistic programs we will need to bring the coming fatty liver pandemic under some kind of control, or at least stasis. This conversation represents a candid, detailed discussion with a major opinion leader on a subject he discusses passionately. So sit back, listen, enjoy, learn, and when you're done, join the discussion in our LinkedIn and Facebook discussion groups. So this morning, we're here with our good friend, Jeff Lazarus, and of course, Louise. Good morning, Louise.
Good morning, everybody.
And good morning, Jeff.
Hi, Roger. Hi, Louise.
So we met Jeff relatively late in the year for the various guests we've had on the 100-something editions of this podcast, episodes of this podcast so far. But Jeff has been spearheading really an important effort that seems to be starting to bear fruit to develop a global, multi-specialty, multidisciplinary public health agenda for how to deal with the coming pandemic. Probably the effort that takes that most seriously on that kind of a far-reaching scale of anything anybody's doing right now. And so, Jeff, I think where I'd like to start is this. I know that before you got to NASH, NAFLD, you had done serious large-scale work in HIV and in hepatitis C. I'm wondering when you came to NASH as a topic you wanted to focus on next, or disease to focus on next, and what it was that brought you there. Your floor.
Well, thank you. And thank you for the kind words of introduction. So back in the late 80s, I came into contact with HIV living in New York City. It was hard to avoid. It was very intense. And when I later moved to Denmark, the Danes were doing a great job, but really their job was taking care of people living with HIV who were dying and providing them with end-of-life care. So it was very devastating to be a part of the movement back then. And in 1998, I joined the World Health Organization and I worked in health systems and reproductive health. When I joined the HIV team, things were starting to change. Antiretroviral therapy was out and it was starting to reach Central and Eastern Europe. And one of my jobs was to work as the advocacy and community relations officer and work with communities in those parts of the world that really hadn't seen the new medicines. And as we started to become successful, a lot of funding was going into this. WHO developed strategies along with UNAIDS and others. We realized that in many cases, people were going to live long with their HIV thanks to antiretroviral therapy, but were going to suffer from hepatitis C, particularly the people who injected drugs. And that was a big problem in Central and Eastern Europe, but also parts of Western Europe. So I got into hepatitis C through HIV. We know the story of the hepatitis C movement, which really took off with the advent of direct-acting antiviral therapy in 2013 and 2014, and then the WHO strategy in 2016, establishing the elimination of viral hepatitis as a public health threat. As I was working in hepatitis and working with colleagues around the world trying to learn from HIV, I started to come more and more into contact with hepatologists and a liver community who I'd been working with a little bit in the early days in hepatitis, but much more from 2014 on. And slowly fatty liver disease came onto my radar. And the more I learned about it, the more I realized we were back where we were in the early days of HIV, which was before I started, but certainly in the early days of hepatitis C, when we had no strategy, no idea of the burden, the economic consequences, and so on. So that's how I got into, say, the fatty liver disease movement, but there's not really much of a movement. And I realized we could learn so much from hepatitis C, from the building of a large movement, largely driven by patient groups, and then working together with clinicians. And we could learn from HIV again, where people living with HIV, or back then they were called people with AIDS, PWAs, led that movement. So now here we are with fatty liver disease with a much, much higher prevalence around the world. a result of, in many cases, of lifestyle situations, diet, exercise, sedentary lifestyle, affecting maybe as many as a quarter of the adult population, and very little attention. It's not on the radar at WHO. It's not on the radar in global development and health agendas. And so I felt that now was the time to try and bring together different stakeholders and build on what we've learned from other movements. Even if they were infectious diseases, we can learn about movement building very much from HIV and hepatitis.
It's interesting listening to you, right? Because I think about HIV and I think about hepatitis. Well, certainly HIV as being in some ways virtually opposite to what we're dealing with here, right? HIV was, at the outset, likely to be mortal in the short run. Everybody who encountered it became ill or just simply started carrying viral loads, was aware pretty quickly of what was going on in their bodies, or at least that element of it, and were aware of the likely outcome if no action was taken. Here you've got, as you point out, a quarter of the world's population, maybe more, sleeping on something with no appreciation of what's going on in their bodies. And doctors will say, well, you got a fatty liver, but don't worry about it. So in that regard, I can't imagine two situations that are more different. What exactly can you take out of the experience with HIV and transmit or translate into this disease most directly or most effectively?
I agree with you. But certainly HIV in many cases has an incubation period that is some years. In some people, it might be faster or slower, but it's often 5, 7, 10 years. In hepatitis C, it's longer. And in fatty liver disease, it may even be longer. So in that sense, they're quite different. But in the beginning, people living with HIV simply didn't know they had HIV. And in fact, late presentation is still one of the big problems. And so when we founded the HIV in Europe movement, developing a definition for late presentation was key. And then we did that again with viral hepatitis. So when you go to the specialist, in that case, and get tested, and you're already presenting with, say, an F3 or an F4, you've been diagnosed late. Some people will say you presented late. We could also say it's the health system's fault. You've been diagnosed late. And so NAFLD has that much longer period, but it's a similar situation. In HIV in the early days, the majority of people didn't know they had it. The majority of people don't know they have fatty liver disease. So it's about raising that awareness, but also being clear what we can do about it. Because also with HIV, because it was an infectious disease, simply preventing other people from getting infected drove part of the movement to find out that you had it, in addition to driving the market to develop medicines. In the case of fatty liver disease, it's not going to be a case of infecting others, but it's going to be a case of possibly developing severe liver disease. And therefore, there's an impetus there to know your diagnosis and to push, again, the pharmaceutical companies and others to develop drugs, but also to address the structured lifestyle interventions that is all we have right now, and it's not being very well implemented.
So, Jeff, take a few minutes and walk us down the path of what you've been working towards with others, what you've been able to accomplish so far, and what you envision for 2022.
So I think things really took off with the creation of the EASL International Liver Foundation. So working with the foundation and its chair, Dr. Massimo Colombo, we had the idea to simply emulate what we had done in hepatitis. And so we did something called the HepCore study, where we looked at core indicators. And we thought, let's do the same for fatty liver disease and see if countries are prepared to address fatty liver disease. So we started with a European study in 29 countries, found no countries prepared. It's a global foundation, so we expanded globally to 102 countries, and again, found no countries well prepared to address NAFLD. We just published that in the Journal of Hepatology. And driving that, we thought, and we brought together many stakeholders to work on that. So experts in every country, different groups reporting and documenting the information, data mining. And so from the development of the preparedness index, we thought, we also need to tell people what to do, and we needed to get consensus on what to do. So we started a large 2-year process of developing a consensus statement that we talked about on SurfingNASH a couple of months ago when it came out in Nature Reviews GastroHep. And that brought together 218 experts who agreed on basic statements about fatty liver disease and sort of concomitant recommendations about what should be done. We've discussed this in the first think tanks. They were held through Wilton Park, a UK-based international global think tank on a range of issues that includes pressing health issues as well. And we were able to talk for the first time a multi-stakeholder group. And it wasn't about clinical developments and trials. It was simply about how do we address this from a public health and systems and policy perspective. So we did that in December 2020. We did it again in December 2021, a bit truncated because of the pandemic. So we hope to have a face-to-face or a hybrid meeting in early 2022. But having those think tanks to really think it through have been really useful. Now we have the consensus statement. We know the countries aren't prepared. So we've been building up an evidence base that's sorely lacking in fatty liver disease, largely based around public health interventions and issues, and related policy issues. And the final piece we just finished was trying to position NAFLD in the framework of the Sustainable Development Goals, to be able to say, if you're addressing this particular goal and it has this particular target, it's also relevant for fatty liver disease, because fatty liver disease, NAFLD, is not addressed in any of the WHO technical documents. It's not mentioned in the Sustainable Development Goals, but we know it's present. We know that when you're addressing diabetes, when you're addressing obesity or even cardiovascular disease, you're helping to improve outcomes for fatty liver disease, but it needs to get firmly on the agenda. So we've been trying to essentially just shoehorn it into the agenda and say, this is what it would look like, in the hopes that we can get other stakeholders and particularly countries to get this onto the WHO agenda. Because I'm a firm believer in WHO, not just because I worked there 11 years, but I mean, this is the global agency to take on the big health issues, and provide the normative standards and guidance. So we do really need it mentioned in the technical documents of WHO. And ultimately, we're going to need a strategy. Maybe it'll be a more general liver health strategy. Maybe it will, in the beginning with hepatitis C. Hepatitis C was always embedded in HIV strategies until finally we could pull it out and say, actually, most people with hepatitis C don't have HIV. So we need to start somewhere. So if we can get fatty liver disease into the diabetes and other strategies where it's actually surprisingly not, eventually we can take it out and get it to its own strategy or action plans, or embed it along with other liver health issues.
Louise, what you got?
I think all of those pieces have been fantastic, and I just love listening and reading that work as well. But what struck me from the recent Lancet Commission, which you were heavily involved in, and what everybody said yesterday when we did a lot of the sessions, was the liver is the window. And I think that was a phrase that came out of that document towards the end. I think it says the liver is the window to health and Europe's health and metabolic health, and we're not doing so well. Because metabolic health has been so intrinsically involved, obviously, in COVID, does that give you, and what can you take from that to use as a lever within the getting NAFLD and NASH, particularly into the SDGs? Everybody's trying to target now, and there's a little bit more awareness of let's make our health better for the future, because this will happen again. We had several warnings with different other viruses. So what can you take? Because you're obviously heavily involved in the COVID as well.
Well, the COVID pandemic, there's not much positive we can say, but it was a unique opportunity to address people's health, not just the health related to the virus, but to say, we know poor outcomes come from a respiratory disease. So this was a chance to say, it's important to exercise. It's important to improve your health. It's important to watch your alcohol intake. And yet, because of confinement, because of a lack of leadership and guidance, the opposite happened. So in general, people gained weight. There was interesting data even from New Zealand, which had a very strong lockdown, that they can actually now track that, obesity has increased, but lots of other countries are reporting it as well. We know from alcohol sales, alcohol consumption went up, and we understand why. I mean, it's a dire situation, but this was a chance for leaders to come on and say, and maybe I'm just dreaming, but to say, wake up and exercise, walk more, count your steps, do it indoors, do it outdoors, but it's going to be better if you get COVID-19. It's also going to be better for all of your metabolic diseases and your health in general. So I've been surprised by the lack of sort of anyone really standing up and saying, this is a chance to try and be healthy in the face of a deadly disease. So we're wearing face masks. Fine, it's not so easy to exercise, but we can also be doing that at home and outdoors. And we're trying to physically distance. That can help exercise. But, we didn't really take advantage of that. And so now with the Omicron wave and we know now a series of lockdowns and restrictions coming, and probably quite a long time more with the pandemic, I hope people will pick up and say, well, at least this is a chance to be healthy, those who have the resources and the space at home or near their homes to do so. And that's why when we positioned fatty liver disease in the Sustainable Development Goals, one of the targets in the SDGs is about green spaces and having safe places to take a walk. And people said, well, how's that connected to fatty liver disease? And we said, well, it's obvious. If you don't feel safe walking near where you live because it's dangerous, or you're in a city in a rough environment, then you're going to lose an exercise opportunity. So we've lost a lot of exercise opportunities during the pandemic. And I think the health authorities need to revive that. And it would just make good sense, whether you're an insurer paying for people's health or a public health funded health system. It's just going to be good for outcomes, and it's going to be good for individuals. I should say good for the system and good for individual outcomes.
Absolutely. And I did have a question related to the preparedness work that you did. Do you have any data that could correlate those who were better prepared did better in the pandemic? Because I know the UK came out of that really quite high in its ability to be prepared to put in a strategy, but I don't think we did too well through the pandemic. And whether or not joining the links to those who were more prepared. Germany, certainly at the beginning, seemed to do very well, and they're quite high up on your list. So is there any correlation that we can take from the more prepared you are to be able to do these strategies, the better you got through or were able to target COVID?
We haven't done any correlation, but I can say one of the reasons some countries were better prepared than others in terms of fatty liver disease is because of the hepatologists there who have been driving some of the policies, particularly around clinical guidelines and multidisciplinary approaches that the UK is doing so well in and so on. What we can learn is the response to the pandemic has been so political and often at times so little evidence-based. So the UK is a good example of a prime minister who's not following the evidence, who's listening to people who are suggesting that the best course is to allow everyone to get sick and develop some kind of natural immunity. Now we've learned that what we knew, we thought that wouldn't work, and now we know for sure it didn't work, and yet they still don't take the needed action. So maybe it's time they listen to some of the hepatologists, or at least some of the public health people who do know what to do. And so the countries don't correlate that well. And then the other issue is it's always nice to look at league tables, and it's fascinating to look at 102 countries and see where you're ranked. But every country failed. This is who failed worse. I mean, a third of the countries scored 0. So even the UK and India, and to some extent Germany, that did better, failed in terms of being prepared. It's just they did a little better, often where the hepatologists had more control, like the development of clinical guidelines or including fatty liver disease in the guidelines of other related conditions like obesity or diabetes.
Yeah, interesting.
It's fascinating. I was struck, first of all, by your comment on the podcast about sharing with one of your European friends that if 50 was the highest score, then everybody failed, and him suggesting what I guess the Americans would describe as grading on a curve, and maybe 40 wasn't so bad. But you didn't say 40. You just said, well, there's other ways to look at the numbers. I think that's terribly self-serving. Ultimately, either you're doing well enough or you're not, and I'm doing better than everybody else doesn't help tremendously. Jeff, at least in the States, and I don't know how true this is anywhere else, I think one of the headwinds you run into is we have this really interesting definition of personal freedom that's evolved that fundamentally says my vaccine is my decision and my COVID is your problem. If you take that into fatty liver, you get to somewhere that looks like I'm going to eat as much bad food as I want, exercise as little as I want, but by the way, it's a systems problem if I then develop disease. And that's happened due to people not having enough knowledge, but in the past, but wanting to do the right thing. But I think in the States now, at least you see 25-30% of the population would militantly argue that it's their right to have a fatty liver. And then you got to deal with the consequences, or we all have to deal with the consequences. A, do you see that kind of thing anywhere else? And B, do you deal with it, or do you have to simply try to flank it, go around it somehow?
Well, to start with B, you absolutely do have to deal with it. That's what public health is about. But to go back to A, I mean, we've seen this with tobacco use, alcohol use. I mean, we see it in any risky or unhealthy behavior, whether it's related directly, to your health or not. So with tobacco, the issue was we want to be able to smoke, but if we get lung cancer, we also want to get taken care of. So there's nothing new there in terms of people wanting to eat and not exercise, and we address it. So in tobacco, actually WHO's first, the first international treaty is around the Tobacco Framework Treaty. We need similar large-scale initiatives. WHO, when I was there in the 90s, had exercise 30 minutes every day. That's great for fatty liver disease. They weren't targeting fatty liver disease at the time. They were targeting more general health, but we need these kinds of campaigns about how to be healthy. There's also some structural issues. Sometimes it's not easy to eat healthily. You might have a short break and you might not have a refrigerator to bring your own food and you're buying nearby junk food. That was well described in the book Nickeled and Dimed in America, where the journalist went undercover and worked in a Kmart and explained how even at home on the salary, she couldn't afford a refrigerator. So she could never it became too expensive to buy food that needed to be refrigerated, and they relied on junk food. And she documented her own weight gain and decline in health. So we need to look at what's going into our food. And that was something that came out in the EASL-Lancet Commission, the problem of ultra-processed food. And we look at this as well with carbonated drinks and how much sugar's in them. I have a colleague who worked for a while at Anheuser-Busch, and one of his successes was to get a little less alcohol into the beer without really changing the taste. People are going to drink their beer, at least there was a little less alcohol. So there's, we need to look at what kinds of campaigns can resonate with people. And sometimes people say to me, and I'd also like your opinion, why would we want to test people for NAFLD if we don't have any medicine for them, because we know they're not going to change their lifestyle and exercise. And I think it's really important and a moral imperative for people to be aware of the health conditions of the diseases they have. And it's one more reason. It's one way we build up the advocacy and the patient advocacy groups is by adding to those numbers, because we know the numbers are huge, just people are unaware. And I probably say a couple times every week, someone contacts me and said, oh, I saw some social media post, you go on about NAFLD, I had no idea what you were talking about. And now my uncle, my cousin, my father, whoever has been diagnosed, and could you share information? And that's only just one person and a few people who contact me, but we need a sea change of people raising awareness. But we also have to be clear that we have to do something about it, because we can't just overwhelm the hepatologists' offices. So we need to be thinking about what kinds of responses. There's digital health responses for some communities. There's exercise. There's just making small changes in your diet and taking this on stepwise. So it's going to be a large public health campaign. And that's why I focus so much on WHO, because it was WHO that led to the eradication of smallpox 200 years after the vaccine was identified. WHO who led the polio elimination and other big campaigns is now leading on hepatitis, HIV with UNAIDS and so on.
So, Louise, Jeff asked for our opinion.
Yeah, I think it's always interesting when somebody uses the argument of we're waiting for medication, we don't have medication. We have really good, effective treatments. It's called lifestyle alteration, and people do alter. I've just brought up a set of figures that I did way earlier on the year. I had 80 patients in this small review, and of the patients that I looked at, when I did their scans, 43% improved their steatosis by more than 1 grade. This is lifestyle, because you know your liver health. None of them are medical patients. They came, they had, and they engaged. Well, you've told me I've got liver fat. Why wouldn't I want to change it? That's so easy. What can I do? That engagement is totally better. But another 43% stayed within the same grade. They didn't get worse. So only 13% deteriorated. And that was because of COVID. They were doing less exercise, so we can link it to what happened. And then they made the alteration after the next one because they found it more difficult. I think a couple of them got COVID and then had problems, and then had poor diet, had really lack of exercise. When you can change on a brief interventional therapy with a non-invasive device 86% of the population, this is the strength that I see, and one of the reasons that I left the NHS to talk about early location. We can alter it, but you've got to tell people why we're altering it. Going back to, we may not have done very well in COVID, and yes, we've got a Prime Minister who you'd think would know better because he's had COVID. He's struggled. And I can tell you from working in ITU, he probably had those 2 people screaming at him all night to breathe, to keep him off a ventilator. Because that's what we do. We spend that time. We make sure you don't get on there. But to then introduce a weight loss strategy and an NHS app where 6 million people registered for that app and more, that is a really good positive. But also measure it rather than just scales. Talk to people as to why it's important. Use that learning moment. We missed all of those opportunities. It gathered stigma in certain perspectives because we were talking about people who were overweight. But we also know that if you've got a big fatty liver sitting under a rib cage, it is really, really difficult to ventilate somebody. AKA, this is not dissimilar in pregnant women. Again, if later trimesters, more pressure, it's difficult. But a big fatty liver underneath somebody's rib cage is really, really tough when you set your ventilator parameters. But we missed opportunities. And for me, it is about education. But people who engage do it because they want it. It's like, oh, don't tell me to do this. It's a case of, oh, I didn't know I had that. How can I make a difference to myself? What are my risks if I have high liver fat? And we talk about them here all of the time. Most people with poor liver health, it is the window to metabolic health. But it's a window that we can open the curtains on. But at the moment we keep them closed. Nobody looks at it. It's stigmatized everywhere. Obesogenic Society. I think there was a very compelling part of the Lancet Commission talking about how we look at these patients in hospital. They don't get the best care. I was part of the NCPOD report where we really rated alcohol care really, really poorly in this country because they don't get access to nurse specialists. If I go into most trusts, anywhere in the world, you get a cardiac nurse specialist, or you'll get a stroke nurse specialist, or you'll get a diabetic nurse specialist. You don't get a liver disease specialist who could help nurses give better care to encephalopathy on the wards because they've never seen it. So I think there's lots of reasons. When people turn around and say they don't engage with their care, it's very difficult to change somebody who's just being diagnosed with a liver disease that they feel is self-inflicted. 30 years down the timeline, it's very difficult to change a behaviour. It's way easier to change a behaviour when somebody says, I didn't know I'd had that. How can I help? So removing that patient pathway and doing a general pathway to wellness rather than, once you get into a medical pathway, you get medicalisation, you get all sorts of other behavioural patterns that we know come with health. and being in that pathway, we have the most effective treatment, and that is early engagement and invigorating that person who finds out they've got something that they can really do something about. But that was just a little snapshot, but 86% of people change their behaviour non-interventionally and do lifestyle.
Yeah, so you mentioned, we have both of those opportunities, and we're failing really on both accounts. We're not diagnosing early, and we're not invigorating. And we have the evidence. We need to build the evidence. We need to get better evidence on the burden, the economic costs, because that's what convinces policymakers and decision makers to take action. As people ask, why is this becoming an issue now? We've become more aware of it, but also, as we live longer, the liver is becoming an issue. So I spend a lot of my time in Spain with one of the longest life expectancies in the world, increasing obesity, increasing diabetes, you see increasing fatty liver disease. So this is an issue that's here to stay. And in terms of the window, the liver as sort of the window on metabolic health, I would call it a window on society. It shows us where we've failed in urbanization. Our cities aren't safe. They're not easy to exercise in. And we've also failed in the quality of our food. And so when working with Henry Mark at the foundation, we were talking about the door that we need to go through to be in the family of other NCDs and be listed in those technical guides and strategies, and the door we need to go through to be a part of the sustainable development agenda. Again, that's why we developed sort of our own framework, which I think needs to become a larger liver health framework within the SDGs, because we need to get on the other side of that wall, whether it's from looking through the window or stepping through the door. I hope we're not jumping out the window, or if it is, I hope it's on the ground floor.
Jeff, my answer to your previous question would be there's no way you can answer that door without a more aware patient population, right? We take our health for granted far too much, even those of us who eat reasonably well and exercise, until we have reason to know that we shouldn't have done that. So Mike Charlton, in the episodes that we did around NASH Tag last year, asked the question, who will be the Larry Kramer of NASH? And one of the things I've realized the more I've thought about that question over the past year is Larry Kramer happened because so many people were so urgent. And he understood how to marshal that urgency in that moment. To the point where on the podcast, when I then turned to Mike and Donna and a couple of other people and said, do you know the whole history of Larry Kramer? Nobody really knew when Larry Kramer was heading people who were throwing pig's blood at folks. They just remembered after he became a more respectable advocate in D.C., but they forgot the urgency that bred all that in the first place. There's no urgency here. And by the way, when urgency happens, people take action. A retired accountant in Pittsburgh goes to his doctor and finds out that what he was told 20 years ago was nondescript fatty liver now is cirrhosis and HCC, and he needs a transplant to live. And 2 years later, you have an organization called NASH Knowledge, which is him and his wife and his daughter, right? An engineer in Idaho goes to the doctor and finds out that, it's, as he puts it, typical American fat boy. He's got a cirrhotic liver, goes home with his wife, they clean out their cabinets. But not only that, they found this thing called the Fatty Liver Foundation, which last month published in a referee journal, and studies with leading academics. Now, not everybody who finds out they have a fatty liver is going to do that, but the point is, you can motivate people to take dramatic action once they understand the scope of the problem in their own lives. And until we've done that, we can't.
No, that's brilliant. And thanks for bringing up Larry Kramer, but really the whole issue of the urgency. What we're trying to do, and I say we, meaning hundreds of really researchers or clinician researchers, is look at what's called the attributable fraction, which just sounds terribly unsexy, but to understand, well, when people do die of liver disease, get liver cancer, what caused it? What's the attributable fraction to hepatitis C or to fatty liver disease? Because, without documenting it, people are dying of fatty liver disease, and we don't know that it was actually fatty liver disease. So often it's put down as unknown, or it could even be put down as something that wasn't the accurate cause. So these kinds of studies become incredibly important to build that urgency. So it's sad to say, but as we find out that more and more people have died and continue to die of fatty liver disease, that's how that movement will build. So it's great that two examples you gave of champions, who went out and founded organizations. But that's what happened in hepatitis C. And obviously that's the whole background of the AIDS movement. And the urgency then was just the sheer numbers of people dying. And like you said earlier, the speed at which they were dying. Our problem is that it's going to take a long time. So people find out when they're 75 or 85, and then they may take action, but we need to get ahead of the curve. That's what I and others have been trying to do through the EASL International Liver Foundation. And when I mentioned there were a couple hundred people on that consensus statement, we've engaged with now over 500 people through Wilton Park. We engaged the Economist Intelligence Unit to help us run 14 workshops around the world outside of Europe, but going to Asia, going to Latin America, going to the Middle East. And there's so many more people out there, but it's about bringing those 500 and then 1,000 and then 5,000 and 50,000 people together and starting to really demand action and make action happen.
Okay, so I have a comment about the disease that may turn into a question, and then I want you to do us a favor and tell us a little bit about what 2022 holds and what you're going to be working on in this space in that year. Comment is one of the things I increasingly believe the more I listen and the more we get into these kinds of issues is that one of the challenges is that NASH is really two diseases. That NASH in F1, F2 is a non-communicable disease in the metabolic spectrum, more likely to have an effect on your heart than anything else at the end of the day. NASH in F4 is somebody likely to be on a relatively rapid path to calamitous liver disease, serious morbidity, or death. How does your work encompass the idea that to understand NASH, you've got to be thinking about both those things, or does it?
I would go back to the example of HIV and probably remember Angels in America. And when you died of HIV, most death certificates allow one cause of death. So if you died of AIDS, in some countries you probably had tuberculosis. So did you die of AIDS or did you die of tuberculosis? Because of the stigma, people often preferred tuberculosis, even though before AIDS, tuberculosis was really, among the most stigmatized conditions. So if you die of cardiovascular disease, I think we need to know if you had NASH as well. Like we need to look at the whole issue of comorbidities more seriously. Otherwise, it's kind of like we're almost losing advocacy tools because people, go down again as a it's not a competition, but they go down as a CVD death, and the whole issue of NASH and what contributed to that cardiovascular disease doesn't get recognized. And it's understanding the attributable fraction to not just the liver-related deaths that I mentioned earlier, but also cardiovascular disease and diabetes as well.
Great. Please take a couple of minutes now and tell us about what 2022 holds for the International Liver Foundation and for Jeff Lazarus on the issue of NAFLD.
Well, many of us sit in academic positions, so we're always writing, but we wrote that consensus statement. So 2022 and beyond is about actioning those recommendations and raising awareness about those recommendations. Obvious places will be in various academic conferences, but also reaching out with the patient groups and others to any setting we can, any soapbox we can stand on to say this is what needs to happen. So we'll be engaging with the NCD Alliance, again with WHO and other partners. The only good thing about the Wilton Park face-to-face meeting getting canceled 2 weeks ago is that we're going to try and do it in 2022. So we have that to look forward. And that's an amazing opportunity to have this professional facilitation through Wilton Park and bring together a range of stakeholders. So here it's endocrinology and diabetes and public health and digital health and liver all together trying to figure out, what's going on. So we'll look at that happening in Q2, and hopefully we'll have that meeting in the Americas that we've been talking about, and also with Global Liver Institute and others that we'd wanted to do this December, to go to Washington, D.C., really focus on the Americas region. As the earlier meeting had been in Europe and more focused on Europe, now we need to make that more global. The consensus statement, raising awareness about the lack of preparedness and trying to, it's a big thing if a country looks and says, oh, we're at zero, why even bother? So we need to figure out where are the quick wins, what are the public health policies that need to be in place, and where can we team up with others? Because if it's about comorbidities, if it's about metabolic health in general, it can't be just going it alone. It's not the liver, again, in a silo, and diabetes in a silo, and CBD and so on. So we need to look at where we can build these collaborations. So some of that work will also be with cancer organizations. We've been talking to the European Cancer Patients Group and saying, look, liver cancer is the second leading cause of cancer in terms of DALYs. We need to see how can we prevent liver cancer, and one of the ways is by addressing fatty liver disease much, much earlier than we do now. It's too late if they show up at that F4 in NASH.
Heartily agreed. So since people are getting to know you and they know Jorn pretty well and they know Surfing NASH a little bit, why don't you talk about do me a favor, the webinar and then the workshop in June, and just tell people a little bit about that.
Thanks. Yeah. So together with Dr. Jorn Schattenberg, well-known hepatologist in Germany, we're going to be chairing a webinar in mid-January that will be open to everyone, and you'll be able to get CME and participate with really top experts who are going to have state-of-the-art brief talks. And it's really going to be, again, to have a discussion for an hour and a half around key issues related to non-invasive tests, comorbidities, multidisciplinary models of care. And that will be a teaser for a face-to-face meeting we hope to have in Q2. So the webinar is really happening because we can't all meet for a meeting in Q1. So we'll have the webinar, but then we'll try and bring together people and have a bit of a different meeting. So this won't be like an EASL monothematic. There might be some cutting edge research presented, but it'll really be about looking at the public health and health systems and policies issues related to NAFLD and try and bring in the kinds of experts from other disciplines who might not attend a longer liver conference, but might come in for an afternoon or a day and a half and look at issues that are or should be important to them if they're working with diabetes patients, addressing obesity, and even cardiovascular disease, although I think that's still going to be a challenge to get them further involved. So that's another big issue for 2022 is to start getting these multidisciplinary meetings together to take on these issues and start to work the evidence base. As we build the evidence base, we need to look at how do we translate research into action.
Great. So Louise, why don't you take the last question and then we'll wrap up and then we'll go on. Okay?
I'll do a quick last question. When you talk about Wilton Park and the WHO and places like that, are the Commonwealth there as a separate entity, or are they there as part of the WHO? The Commonwealth, as you know, is the Commonwealth Alliance of all of the countries that used to be part of the British Empire. Now, that's 54 countries and 2.4 billion people. Now, they have their own health connections between the Caribbean countries, things like that. So do they sit as part of a pocket within the WHO, or do they just get, because part of the strength of the Commonwealth is the Commonwealth linking, and they've been there. India, obviously, is one of the biggest countries in the Commonwealth, but lots of low socioeconomic countries. So how does that strength of that organisation get utilised within what's going on at the moment?
It does, and that's one of the reasons we're working with Wilton Park, because when a Wilton Park report comes out, it's heard. I mean, it's a strong logo on that cover. There's quality in the pages. And so in a sense, anyone can run a meeting and write it up, but few people can do it as well as Wilton Park can. So, Nancy Lee and her health team now with Henry Mark just do this amazing job. And that's why we went to them specifically. And also knowing that they would have that distribution, being an arm of the Commonwealth and of the UK Foreign Office. The same reason we went to the Economist Intelligence Unit, we knew that we'd have excellent facilitation, we'd have convening power, and ultimately you'd have a report that was put out by The Economist. That's incredibly important. When we've invited WHO to attend, and we did have a director of well-being, Dr. Rudiger Krich, who spoke at the last Wilton Park meeting, that was incredibly important because he's a well-being advocate. So he was learning about NAFLD and also helping us, and recognized it's important, and helping us understand how to navigate WHO in order to get it better recognized. So we've had some good collaboration with the NCD department. A former student of mine is there that's helpful, but I also worked 11 years at WHO, so I know some of the folks, and we're building those bridges. And we don't want to come in and say, oh, we're a single issue, lobby here. But I mean, this is a big issue. It's almost a quarter of the world's adult population, and it's so intricately linked, particularly with diabetes, but also with other disease areas that WHO is addressing, that we really want the NCD department there to pick it up and to run with it, and then just call on us to contribute as technical or advocacy experts as they need.
Fantastic.
So, Jeff, quick last question. It's all great. And here's the quick last question. We get together 12 months from today to do the year-end interview for 2022. What progress do you expect you will have made?
I hope in one way or another, some WHO document is going to be mentioning fatty liver disease in its pages. I hope we've established that global movement in a very light-handed fashion, but that we have a governing structure where anyone who's interested in being involved in it is, and that we can start to work together to coordinate. So not to control, but to have common goals that we can be working towards, which would include WHO. When I say WHO, I really mean it's over 190 member states. So getting things onto the WHO agenda, I think we can achieve that. And I think we can get this global group together in one fashion, one form or another. So we can start to also give space to people who want to work outside of maybe their national setting and don't have the framework to do that. Because right now there's no organization like the World Hepatitis Alliance, like the International AIDS Society, and so many other truly global groups that have members from around the world. And that's what I hope we can see. Whether we'll all be ready within a year, I'll let you know in a year. You'll know. I hope so, but that's the ambition.
So we intend to keep paying attention. And as you and I discussed, we're going to commit to do at least 4 episodes in 2022 on this subject, and maybe get involved a lot more than that. We'll figure out how that plays as we go along. So, Jeff, in closing, after having spent a career in pharmaceutical marketing research, which was occasionally interesting but rarely edifying, one of the things about what I do now is I get to spend time with people whose work I think is truly world-changing and sometimes heroic. And I count you among the world changers and, frankly, among the heroes that I know. Thank you so much for joining us today. Have a great rest of your year-end holiday, and we look forward to seeing you back here.
Well, that's amazing, Roger. Thank you so much, and thank you, Louise, and stay safe through the holiday season and beyond.
And yourself. Have a great time.
We'll see you in January when we figure out how we're going to help you folks or cover the webinar. Okay, take care. Bye-bye now.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. Join me again later today, January 2nd, for our conversation with Andrew Scott of the Global Liver Institute. Bye-bye now.